So have you thought about grounding? I feel like we're just repeating a conversation from the past. So tell me your thoughts on grounding.
So you have a standing desk. You must definitely do yoga and
Cold
compost and
plunge. Yeah, you got a cold
that.
plunge every day. If you have a standing desk, you definitely cold plunge.
Devon is he's into cold therapy. I know that. We've talked about this. I was into it for a while, and I gave up on it.
You gave up on it? Why are
I
you
was
a quitter?
expecting to drop 50 pounds, and it didn't happen. So why subject myself to that torment?
No, I just use it to wake me up in the morning. That's pretty much it for me.
You know how I wake myself up in the morning? Right here.
Yeah,
Nice cup of
and
coffee.
Let me
in
tell
the
you something.
afternoon.
Yeah, exactly. Let me tell you something. I need all of the tools to wake me up all the time. I'm a tired boy.
Hello and welcome to the Best DBC Podcast, the world's #1 podcast covering all topics related to direct primary care. I am your host, Wayne Lowry. No, I am not a doctor, but I will prescribe you all the fun you can stand. Joining me today is two tech geniuses, Jonathan Minson, CEO of Calvient, and Devon Mobley, self-proclaimed tech wizard and product guru, which we will be the judge of that. We're excited to have them today. And also, just a little note for our audience today, they're going to be revealing a brand new product, never before announced. So we're very excited that they chose the Best DPC podcast to make that announcement. Take that, Joe Rogan. I know you think you're the bomb diggity, but we get breaking news right here. So there you go. So excited to have you guys. The Best DPC podcast, breaking news and breaking hearts since 2025. So welcome,
Glad
guys.
to be here. Yeah.
Thank you so much for having us.
So before we get into the big stuff, as much as I'd like to just rip off the Band-Aid and just jump into the meat of the conversation, I want the audience to have a chance to kind of get to know you guys. Jonathan, I've known you for a few years, some 20 years, I believe. Devon, I met you a couple of weeks ago and I judged you instantly as being one of those guys that cold plunges and gets grounded every morning with his bare feet in the grass while doing yoga. And I mean, I don't know if that's true, but that's what I'm going to put out there for the entire audience.
Sure. It's fine with me. As much as I'd like to fight you on it, maybe some of those stereotypes stick.
Okay.
It's mostly true.
Mostly true.
I've known Devon a long time. I'd say that's like 70% true.
Well, so both of you guys are based in Oklahoma, correct?
Right? Oklahoma
That's right.
City.
Both Oklahoma City. So let me ask, I guess, the most important and pressing question. I can see the highlights of a logo on your shirt there, Jonathan. Are you an OU fan?
I am an OU fan, like most people in this area. This shirt was a gift to me. I didn't go to OU, which I know there's a stigma about people wearing OU gear when they didn't go to the school. But I've loved OU since I was a kid. This was given to me as a gift, and I love it. It's a great shirt. I'm mainly an Oklahoma City Thunder fan, and Wayne, I know you well enough to know that you're a Rockets fan.
I am a Rockets fan.
Yeah.
You are correct there. I like the Rockets. I like the Astros. I like the Texans. I like the Houston Livestock Show and Rodeo. I like Space City. I like all of the things Houston related. No, soccer is for quitters. No, I'm not a soccer fan. No. So
strong opinion, strongly held.
So, but you know, what about you, Devon? What are your thoughts on OU and specifically joining the SEC?
Sure. So I, unlike Jonathan, did attend the University of Oklahoma. But you know, the gate's wide open. We welcome everyone. So I am actually a native Texan, but I moved to Oklahoma City and you know, have been here since 2004. So it's pretty much home.
Nice. So what made you leave the Lone Star State?
Family changes. So my family got their start kind of in the oil fields of the Texas Panhandle, which is, I'm sure you can attest, the worst part of the state of Texas. But so we just, whenever my family was looking to transition to new lines of work, that Oklahoma City was a natural landing spot. It's kind of the close big city to the Panhandle, to be honest.
Yeah. Well, I will say there is no bad part of Texas. So if anyone asks, officially, my position is there are no bad parts of Texas.
He's
In
trying to
fact,
one up me with Texas love.
well, I have no choice. So Panhandle of Texas, I lived about 6 months up in Amarillo, and I will say this: the coldest winter and the hottest summer of my life
Mm.
were in Amarillo, Texas. But that's where my wife was from, so
Mm.
I can't
Did
Sounds
you
flattering.
ever?
complain. I can't complain too much.
Did you eat the 72-ounce steak, Wayne? Have you ever taken a shot at that?
We were talking about not wanting to be a quitter. So
I
earlier
was
before the pod,
gonna
I'm
say.
not
Yeah,
going to start a 72-ounce steak when I know I can't do it.
yeah,
Uh,
that's fair.
I'm more of like a my eating or my skill set when it comes to devouring food is more of like the long approach. I'm more of a marathon runner, like eating all through the day, way too many
Yeah,
calories versus that one go.
Sure.
Not really a
I,
sprinter.
I spent time with Wayne in the summer before he got married, and I love to tell this story. We ate a lot together. We actually lived in the same house together for a month,
Yeah, the
and
cradle.
he he'd always say when we go out to eat that I'm watching my weight. I got to fit into my tux, so he'd order half portions of twice the amount of food
Yeah.
everywhere we went.
Hey, it's
Which
all
I don't know about the
psychological
math there.
warfare. It's
Yeah, I
psychological,
suppose so.
brother.
Yeah, I guess so.
If you order half portions, then and you can order as much as you want as long as it's half portion. Take home the rest. I don't know. It's a win-win.
Yeah, that's like why I get the milkshake and the Diet Coke. There's a counteraction there. Yeah.
Yeah, cancels out. Everybody
hmm
knows this.
hmm
So, favorite diner or dive in OKC. So next time I'm up there, in fact, I'm thinking about. Well, I think I'm going to be in Tulsa maybe in a few months. At the isn't that where the Free Market Medical Association conference is this year? Is that in
That will
Tulsa?
actually that will actually be in Oklahoma City this year.
Ah, it is Oklahoma City. Sweet. So I
Yep,
may actually get to see you guys in person potentially, as I understand y'all are going to be there as well.
absolutely.
That's right.
Awesome.
That's right.
So when I'm there, since we're talking about food, what's a good diner or dive, some place that we can only get there that you can't get somewhere else? And don't say Brahms, because I mean like everybody
Yeah,
knows
yeah.
that.
Devin better answer this question because I probably would say Brahms.
So let me ask you a follow-up question real quick. So are you like, I want to try, the bacon and eggs or whatever, or hamburger at anywhere I go, or are you semi-adventurous?
I'm pretty adventurous. I mean, I'll pretty much try anything at least once.
The best restaurant probably in Oklahoma City, and it is semi hard to get into, is Cafe Cacao. It's a Guatemalan breakfast food restaurant, open from 6 a.m. or whatever to like early afternoon. Many people, if you were to look it up or ask around, that's a common recommendation, and it's hard to find something that people won't love there.
Well, when I'm up there in a few months or next month, whenever that is, calendars are tough to follow.
Yeah,
Whenever that is, I guess you'll be buying me breakfast. I appreciate that. Thanks, Devin,
sure,
for the
I'd be
offer.
happy to.
Yeah, Devin.
Awesome.
Yeah, it's on Devin.
I'll bring my yoga
On
mat.
Devin.
I will buy you Brahms if you're interested. We can
I'll
get the bag
follow
of
up.
burgers. It's $5.
Maybe I'll just order a half portion with Devin, and that way I'll have room for a
Yes,
half of an extra large milkshake with
Sounds like
you.
a good strategy.
yes,
Yeah.
absolutely.
So, to kind of dive in a little bit to a little bit of industry specific conversation, Devin, I understand you started your career as an IT tech in a hospital. Is that correct?
Yeah, so I mentioned earlier that I graduated from the University of Oklahoma, and I exited and tried to enter the workforce with a lucrative philosophy degree. So the only skill that I really had to really leverage was that I had built computers, grew up around computers, was really fortunate, just frankly, happened to have an uncle that was into building computers and gaming and that sort of thing. So leverage that into an IT sort of desktop support role. And that actually was at the specialty hospital that I met Jonathan at. So the kind of the without bearing the lead there, I got my start into the software side of technology and in healthcare all through Jonathan's help. He was my mentor and taught me how to code and and then now fast forward to today, and we're business partners. So that's kind of the short version of that story.
So you kind of gravitated more to the IT tech side. Now, Jonathan, you've been involved in working within the hospital industry, in the medical industry, healthcare industry for some time. In fact, that's
Yeah.
pretty much been the focus of your career, correct?
I had one brief stint at a golf course, cleaning golf carts and cooking in the grill. But most of my career has been in healthcare. My first job in healthcare was not in IT. I actually had a couple of healthcare related jobs, one in medical records, one as a medical assistant. Um, and then one summer, there was an opening in the IT department, and I jumped on it. I love computers. I kind of thought that's what I wanted to do professionally, and so I made a pivot into technology. But actually started on the medical side, working with some cardiologists. So that's been my start. And I was fortunate that around that time, the system we were at created a software development team. I knew how to code. I'd gone to school, not at OU, but I went to college with the MIS degree, and I helped create that team. We brought in Devon a year or two after that, and that really blossomed and grew into something really big and special. And around 2020, um, we kind of were reading the tea leaves, and I think we had the itch that let's go build something, let's go start something. We've been working for a system, done a lot of great work, loved them, and cherished our time there. But we were ready to build something new. And so the last few years, we've been one other co-founder, but we've been here at Calvient building some great stuff.
So you're building stuff related to tech, right? So let me ask, why is healthcare tech so crazy? Why does it drive us so crazy?
Yeah, I don't know that I have enough time, but I will try to. I'll lay out a few reasons. So, anyone who uses their patient portal, if you have a doctor and they have a patient portal, it's probably My Chart by Epic or what used to be called IQ Health by Oracle or one of the big patient portals. They're horrific. Like you'll get much more mileage out of your bank software, out of your video streaming software, out of your podcast software. Those are intuitive, great platforms. The best healthcare tech, especially facing the consumer, is very poor. And a lot of this goes back ultimately to some regulatory decisions that were made in the late 2000s. If you've ever heard of the term meaningful use, what happened was in 2000, late 2000s, the government created a program to incentivize, a well intentioned program, I should say, to incentivize health systems to implement computer systems. And what unfortunately happened is it essentially locked in technology at 2009 levels. And since then, we've seen a robust explosion in all kinds of new tech, from mobile to cloud based now to AI. But because of the barriers to entry that were erected by the government and lobbied for by the biggest companies in healthcare technology, they know who they are. Um, because of that, it's created barriers to entry so that if I had an idea to go build a new electronic health record, mobile first, built on AI, all the great bells and whistles, the amount of the legal battle to become certified and to be a part of what Medicare calls the certified EHR technology list, to get my Chapel ID, all the things I have to do just to play the game. It's just way too expensive for any startup unless you're incredibly well funded or you're a company like Oracle who just straight up acquired Cerner to get into the game. And so there's a lot of reasons. HIPAA, everyone's scared. I think fear has driven a lot of decisions in healthcare technology,
Yep.
unfortunately. But for a large part, it really goes back to those early days of meaningful use and a well-intentioned regulation that had the effect of
No,
really shutting down innovation.
let me press you on that for a second. So you said it's well intentioned. Do you truly believe it was well intentioned, or do you think it was some big groups that had lots of money that wanted to lock it in so they could control uh, the medical industry?
It depends who we're talking about. I do sincerely believe the people who passed it. This was the part of the American Investment Recovery Act. The people, and that was passed in the Obama years, but it was really talked up during the Bush years as well. So this is a bipartisan effort. This isn't one
Hmm.
party versus the other. Both parties were on board with this. I think the people who passed it were well intentioned, because the idea was we want to create a federal program to reward financially systems for implementing these computer systems. At that time, a lot of the world was still on paper. Um, they still are. You always hear this joke is that you thought we used a lot of paper, then we implemented the EHR, and we use even more paper. But that was well intentioned from the legislative bodies. I believe that. Now, the lobbying groups, There is no doubt in my mind that that was an effort, especially when they created the ONC certification rules. That was an effort to create legalized barriers to entry in the healthcare tech world, and that has stood the test of time to this day. And so there are some things that you just kind of can't touch as a startup because you're encroaching upon EHR land, and when you're in EHR land, you're encroaching on regulatory land. I do believe that was probably a lot of self-interest going on and not looking out for the good of the consumer.
So we live in I don't know if y'all noticed or heard, but we live in a new age, a new era. Things are not exactly the same in DC as they were in 2009. We'll get into some of the what the future might hold, but since we're talking about this as almost from the standpoint of whose fault is it, and we're looking at basically the culprit that's holding back advancements in healthcare tech. In your mind, Jonathan or Devon, either, do you still see that this legislation is the number one culprit, or are there other things that now have come into play that would really continue to reinforce? Let's say that we waved a magic wand and the law was changed. What would need to happen to enter into that space, and who's going to continue to hold us back or hold America back on healthcare advances in tech?
Yeah, the question of who's the bad guy. I mean, it's easy to point fingers and say, well, the payers are the bad guy, or the big EHR companies are the bad guy. And the
You heard
reality
it
is,
here
all
first. You heard it here first. The
yeah,
EHR
I know.
companies are the bad guy. I was waiting for that sound bite. All right.
Yeah,
Sorry,
please,
Jonathan. Go
yes,
ahead.
yes, absolutely. It's
Go
easy to
ahead.
say they're the bad guy. The reality is, everyone's just following incentives. The incentive structures exist. It started with Medicare. I'm sorry, it started with meaningful use as a part of Medicare. Now it's MIPS. These are just incentive structures. So the health systems, the EHR companies, the payers, they are all just following the set of incentives. Um, I and ultimately the consumers have a stake in this as well. I mean, I think one of the realities that the next generation of healthcare leadership has become aware of is that the younger generation of patients will not put up with bad technology like the older generation would, because they're accustomed to being able to book online, to pay my bill online. My dad, he needed to book an appointment, and what he did is he got in his car and drove to the office and walked in and said, "I want to book an appointment." I would never do that. If I talked to if I called up a doctor's office, which I don't even want to call you, I'd rather fill out a form on your website. But if I called up a doctor's office and they said, "Yeah, drive down here during business hours, take off from work, we'll get you in," I would say, "See ya," and never talk to them again. And I imagine that people younger than me have even higher standards. So consumer behavior does drive a lot of this, and I do think there's going to come a critical mass of young consumers saying, "We're not going to deal with these horrible systems," and there will be pressure on the health systems from a strictly competitive standpoint to get their act together. So I don't know that there's a single bad person. Everyone's following incentives, but the answer to this one, I would love to see a deregulation of certified EHR technology, but I would also love to see more consumer pressure from patients saying enough is enough.
Yeah, I appreciate that. I want to take a quick break to talk about bestdpc.com. Are you a doctor looking to break free from the headaches of insurance and take control of your practice? Or maybe you're an employer searching for an affordable healthcare solution that actually works. At bestdpc.com, we cut through the noise and connect you with the country's best direct primary care clinics. Whether you're a patient tired of surprise medical bills or a physician ready to build a thriving membership-based practice, we've got the tools and resources you need. Find the best DPC doctors near you, get expert advice, and take the first step towards a better healthcare. Visit bestdpc.com today and see why direct primary care is the future of medicine. That's bestdpc.com, because great healthcare should be simple, affordable, and built around you. Devon, let me switch to you for a second and ask you a question on the tech space.
Yeah.
You've seen the provider side up close, working in that industry and working up close in that space. What do you think the docs are facing the most as far as the challenges with all these regulations, and specifically thinking about our audience, a DPC based audience, people that are
Yeah.
already maybe frustrated with the traditional healthcare model and are looking at direct primary care.
Yeah.
From your perspective, what are some of the tech headaches that you think traditional docs are facing, and what can be fixed or changed for a DPC?
Yeah, for sure. I think what I primarily see on the provider side is this growing over time, um, kind of a bit of a boiling frog effect in which these providers are their time with their patients is being taken away. So at what there's it's like death by a thousand cuts. One cut is that they're increasingly having to be more strict in terms of how's my note look, what codes am I using, what payer, even like what's my payer mix, and kind of being aware of that. So you know thinking of those who are in traditional settings with insurance mixes. But then you add things like, um, hospital overhead, small business in general, and just the issues that it may that come up when it comes to running and growing and maintaining a small business. And it's just one thing after another. Jonathan mentioned MIPS. That's another piece of regulation that affects particularly small provider practices. And then you have staff turnover. I just feel like one of the things that happens is that there's no time, no bandwidth anymore for providers to just sit and be with patients and to be able to then also have time to construct a well thought out, narrative of the care. And frankly, I think, kind of looping tech into this, one of the things that is somewhat to blame is the fact that we did do what Jonathan mentioned. We pushed for these systems to be the source of truth. Now, for people who don't know technology super well, one of the things that you have to kind of understand and distinguish is that doctors and clinicians and hospitals work off of what we call unstructured data. So narratives, they're typing out things, they're talking, they're dictating, they're getting information from a conversation like we are right now together. But computer systems are like, just think Excel spreadsheets. They want numbers. They want these little fields that they do one specific thing, and they have one kind of label, and you know what it is. And up until the age of AI, which is a whole other different conversation to get into, we've not been able to really find the right way for that type of information to work together. So why am I saying that? Well, I'm saying that because part of what gets a doctor paid, what allows them to, report on their outcomes, report on their measures, do all these various things, is partially a clunky workflow for just, I had a really successful patient experience, but now I have to make sure that I'm putting this all in the proper way and I can't make any mistakes. I have a ton of pressure not to make any mistakes. So I think like in the DPC world, I think that there's a fantastic opening, and why we've seen such an explosion of that since in the past, half a decade or a little more, has been partially because physicians can be physicians again. Front office staff can be front office staff. You don't have, a kind of like 6-to-1 billing office to rest of your staff ratio where most of your operation is just figuring out how to get paid. It's simple. And then that does translate to the software side. Folks who work in this space, for those who didn't know, can provide software that don't follow the types of regulations that Jonathan mentioned earlier. They can provide more open software that is easier to use and just kind of solves the problem, if that makes sense.
Right. Yeah, I'd like to piggyback on that because you're right. This is being enforced through Medicare Part B. If you're out of the Medicare game, you are free. You can get and go look at some of the EHRs that support direct primary care or other non-Medicare, domains, and the cost is an order of magnitude less. So much of the cost is because of these certification rules. And I've heard doctors so many times say, I'm not a coder, and they mean in the sense I'm not coding ICD-10 codes, and I don't want to treat the computer. And I've been to doctors where they're treating the computer. I mean, they don't even look at me. They're just clicking, clicking, clicking. And there's really two reasons that's happening. One is because of meaningful use and now MIPS and MACRA, which says you've got to do things like if the patient has sleep apnea, you have to ask them these 10 questions and document them in the chart in very particular ways. So tedious and slow. And that's one of hundreds of different measures that different specialists are having to chase after. There's the regulation side. But another, maybe even more insidious nexus of bad incentives comes together on the payer side, because
Okay.
payers, you want to upcode. I mean, we don't like to talk about it, but I want to, in order to get paid as best I can, make my patients look as sick as they possibly can. And that
Mhm.
obviously feeds into value-based care, away from fee for service and some other models that we thought were bad, and maybe they were. But EHRs made that easy. And I've worked with providers and on the EHR side, so I know I've been privy to these conversations of, hey, can you help us see that maybe we could code this patient in such a way that they have a certain condition or meet a certain set of criteria to bump them up into the next level on an E&M charge. I mean, that not only has an impact as a consumer, that has a population health problem, in that we are incentivizing doctors to make patients look sicker so they can get paid more. So there's an unholy alliance of technology and payers coming together to create a really perverse incentive. And and that's why doctors that are in the Medicare game are spending so much time on the computer. Now, I got to be careful. Doctors are not the villains.
Of
They
course
are
not.
doing what they're told by their administrators to do. Doctors don't like this at all. I mean, they will tell you they hate this, but it's the
Well,
Yep.
game they have to play.
Well, and that's why we see a growing movement of doctors all across America, doctors, nurse practitioners. Uh, we see them all jumping into the DPC space because, frankly, they have the freedom and flexibility to work in that space where their hands are tied, where they're taking their time, charting on the weekends and doing paperwork on their vacation,
That's right.
opening up their life to, be able to be a parent, to be a community member, and not just strictly working all the time just to meet up with all those regulations. So I mean, that's a big reason why I've been such a fan of DPC for the last several years, is get to experience what these providers and the change it makes for them. I mean, in a healthy provider, what does a healthy provider do? It provides healthy outcomes for his or her patients. And
Right.
so
Right.
we're very much in alignment on that, the challenge that's facing. So speaking of, I do want to transition, if that's okay. We're going to dive into more talk very specific to DBC in a moment, but I think it's time to make a big reveal. And I'd like you guys to talk a little bit about what you're doing now, this new project. And so let's just jump right in and say,
Yeah.
Allora Health. What is it?
Allora Health, Devon, tell us all about it.
Yeah. So Allora Health is a platform that we developed that the entire mission of it is to provide accessible and affordable care to anyone who's searching for it. Imagine a place where you could actually just go. It acts like a shopping cart. You search for, very similar to how you might envision searching for any small business or service, geographically located. You're able to see things like ratings and things like that, and then of course pricing. So what's the pricing? What does it cost to be able to go see this particular physician or specialist or physical therapist, or to buy this particular drug? So it really is, Allora is really at its heart a cash pay marketplace platform. And so, without kind of getting too deep into it, but kind of explaining how it works slightly, for patients, you can search, you just search for the care that you need. And then we also are trying to align, the different incentives based on um, employers as well as providers. So the other half of this is we really want to work with providers, people who probably have that awareness, like the DPC audience, who they know how hard it is, and have been in those shoes of trying to run a clinic where you're waiting on claims forever. So our main goal with Allora is to be a facilitation platform. So taking those funds, patient pays for a particular service or bundle that goes as soon as possible, day of service, to that provider. So we are not creating a claims or claims like process. This is truly just a facilitation of funds with the lightest possible amount of work in the middle. Like, in other words, we're trying to make sure that the fewest amount of steps are between that patient in their transaction and the provider providing the services. And then, of course, we want to be able to work with employers. So we did build into our platform tools to be able to associate patients who are searching for care with an employer plan and work side by side with direct primary care and other first level options, as well as brokers and employers, TPAs, who are in the sort of benefits side of things.
Well,
So that's Allora in a nutshell.
yeah, let's dive into or let's kind of look at each of those segments kind of one by one
Sure.
and maybe discuss some of the benefits of it might be like looking at an employer group, for instance. What's the benefit for an employer group to utilize this software?
Yeah, absolutely. So the biggest benefit that we see being able to provide employers is that if you're an employer, especially whenever you are, well, let's just take for example just the general broad economics of it, right? More and more we are seeing employers looking for more affordable healthcare options. Unless you have a super high acuity population within your employee base, and those do exist, and those commercials, full insurance makes total sense for those people. But a lot of small businesses got to find a way to save some money somewhere. And if you're providing health insurance benefits, then you might be looking at a level funded or partially self funded or a fully self funded option with a broker or whatever. And what we want to be able to provide is, again, another one of those first level options, so that like a TPA would work with one of your employees or whatever. Let's coordinate what's the best option for you, what's going to be the lowest cost, but an intersection of the lowest cost with the best sort of outcomes and ratings and those sorts of things. So from the employer perspective, I think it's really just a matter of, if you can have the access to where your employees are accessing cash pay rates, then you're ultimately going to save money, and that translates to really important downstream effects for small businesses across the United States, right? So that's how I see it. Jonathan, I don't know if you add anything to that.
Yeah, I mean, I think that what we're seeing here is a confluence of different incentives that have come together at the right time. You mentioned employers; they have a fiduciary duty. There have been lawsuits in the last 2 years against employers that have let their health costs get out of control.
That's
And
right.
we mentioned earlier the Free Market Medical Association. We're proud members. We're sponsors. In fact, shout out if any of the audience, if they're going to be in Oklahoma City, Calvient will have a table at the conference. Come talk to us. But one of their pillars is transparent and clear pricing. A lot of times you end up with these pricing structures that sound great, but they create negative incentives. So one classic example in the broker world is, we will save you a percentage, or we will charge you only what we save you. Well, that sounds great. I don't have to pay unless I save money, but that creates a negative incentive where we can let prices continue to creep up, or maybe we don't negotiate contracts to the best of our ability because we're okay with higher prices, because maybe I can let that price go up, then bring it down and charge you a percentage of that savings. So i- employers have a fiduciary duty to their employees to take care of their money. This is, I mean, we're managing your health. You work for us, but you're part of our group, and we want to look after your best interests. So employers have a lot of pressure, downward pressure, to get these costs down. Providers are up against a completely different set of struggles. They're dealing with pre-certification and benefits verification, and it may be 3 or 4 weeks before they can even get you scheduled, because they're waiting on United or Blue Cross Blue Shield or Cigna or Anthem, or you name them, to even approve your test or procedure, or even your specialty office visit. And then when you actually get in, you may pay a copay, and then it may be another 9 weeks before you even get paid. And providers are of the mindset saying, we'll post our prices. If you can pay us same day, like you would for any other service in the world. I mean, can you imagine a restaurant working like this, where I got to file 3 weeks in advance to get pre-certified to go eat? And then when I get there, I pay a little bit of my copay, and I say, you'll see the rest of the check in 9 weeks. I mean, no sane business does this, but it's what providers are forced to do. So you
Mhm.
have providers saying, hey, we'll give our cash prices if you can pay us same day. You get employers saying, hey, we'll take your cash prices because they're so much lower than our negotiated contracts. And then what you need is a technology platform that brings those worlds together. That's Allora. That's why I always call it the DoorDash of healthcare. I don't very often, if I want food delivered, or if I'm going to go order it or pick it up, even, I just go to DoorDash. I
Yeah.
know that these different restaurants have their own ordering services, but it's a convenient place for me to compare. And maybe I'm feeling like Chinese food, or 20 half portions of Burr's Cafeteria, whatever.
Yeah.
But
That way
that's
you
what we
can
want
eat
Allura
twice
to
as
be.
much. You can eat twice
That's
as
right.
much in size portions.
That's right.
Good strategy.
That's our strategy. Yeah.
Take a quick break to talk about scalebyseo.com. If you run a direct primary care clinic, you already know the power of patient relationships. But here's the thing, patients can't sign up if they can't find you. That's where Scale by SEO comes in. We help DPC clinics get seen where people are searching, so you're not just waiting for word of mouth referrals. With the right SEO strategy, your practice becomes the obvious choice when people are looking for better healthcare options. If you're not showing up where they're searching, you're missing out. Be visible, get found, grow your practice. Don't leave growth to chance. Visit scalebyseo.com today and let's get your clinic in front of the right people. So, all right. So how does that then, obviously brokers, you've got the whole insurance industry associated with employer groups. So obviously there's navigating, finding the right brokers, TPAs and others that might work with you. There's going direct to employers. And again, this is a little bit of strategy of where and how this gets rolled out. The third piece of this would be, the referrals that might could come through DPCs as far as their referral base. So if you were going to be talking directly to a DPC, or let's just say on a DPC related podcast, and wanted to pitch this service to a DPC clinic that may be referring out hundreds or thousands of services, and looking for a streamlined approach, what would be your pitch to them?
That's right. Yeah, we see a ton of I do hate corporate buzzwords, but synergy with the world of DPC. And I think that it kind of comes about in one of two ways. Now, your experience, Wayne, might be different, and people who are in the world might be different, but not being like specifically from specifically the DPC world, people I know and people even who are really knowledgeable about healthcare, they're not always educated on what direct primary care is or the benefits that it provides. So I think one of the things that Allora can do is we want to connect to primary care as it should be, right? Primary care has a very important function in the healthcare ecosystem. And, none of us, even if we were to provide, a little bit of guidance on like how to go which way or another, that does not replace primary care. Primary care still needs to be the, again, primary place where a patient is getting the clinical advice and sort of diagnostic input output that just needs to happen. It's just how healthcare should be when it's done well. When primary health is done well, I think that a lot of things downstream do get fixed. So in other words, we see that like we want to connect more patients with primary care. So whether that's from an employer group who contracts with a direct primary care group to be one of those first level options, or even just from I think another component of this is that we do offer sort of direct to patient, direct to consumer interface. So you can go to Allora and search for care without necessarily being associated with an employer. I think given the economics that we're talking about, if you're an employer or a part of a group or whatever that isn't necessarily in the know about these cash pay affordable options, you might just think that you are kind of out of luck. So all that to say that if you are looking for care, but maybe you are underinsured, maybe you've opted out entirely. I know people who have done this, who have changed career paths. They've taken a little bit of pay cut. They have a family and they want to keep those funds. They can't afford their new company's premiums split, so they just kind of opt out. Or maybe, and I think that this has been told to me over and over again, more of an opting into the high deductible version of the health plan offering at an employer. So what I'm trying to say is you have tons of people, whether uninsured or underinsured, who can benefit from connecting with direct primary care clinics. And we want to be a direct facilitator and front door for that. And the second component to it,
let me ask you a question real quick, if you don't mind. Let me jump in, because you were just mentioning the high deductible health plan. So you're thinking this might be a product that, say, someone is already, they're offered the insurance product, but instead of saying, hey, we'll take the $1,500 deductible for our family, and with the high monthly uh, costs, we'll take a high deductible, a $5,000, $10,000 deductible plan. It'll be a lot lower on our monthly cost, and then we can use this product first, use Allora first, to then
That's right.
use that as the means of cash pay to avoid even maybe hitting our out-of-pocket deductible and out-of-pocket expense.
That's right. I believe increasingly you're seeing a sentiment kind of parallel to what Jonathan was describing earlier of the increase in technology and increase in kind of consumer pressure for certain expectations of businesses, including those in healthcare. I think the parallel that we're going to continue to see is people realizing that they're not getting the value out of health insurance. People already feel this. They already feel this, but we have to be kind of, I think, frank about how consumer psychology works with healthcare in the United States. There's a reason why large direct care groups are, and I'm talking more of kind of like your large, high scale, they were acquired by your Amazons, Walmarts, whatever, why those efforts are not necessarily working. Part of it is the assumption is that people want to pay for their healthcare. People in America, let's not get it wrong, they still want insurance to pay for their healthcare. But I think increasingly the economics are going to press them to say, like, you know what, I am fed up. I am totally fed up that I'm not getting the value out of this. I don't know if this $1,500 MRI is going to go towards my $5,000 or $10,000 deductible. So I would much rather just purely and simply reduce my out-of-pocket costs by getting a $300 MRI, or and getting that ordered from a direct primary care physician rather than risk it, because that money is important for me month to month. So I think we're going to continue to see that, and I think that Allora has a really important part to play in that.
Yeah, and I want to add on to that with regard to referrals, that direct primary care, this helps them create a network of like-minded providers that they can refer within. One of the challenges that independent practices have in DPC clinics is that these large health systems, they self-refer and they get safe harbor under the Stark law. It's a huge competitive disadvantage. I mean, that's talk about regulations that have to change. That's one of them. I'll give you an example. Last Christmas, a, a year and a half ago, I was playing football out in the front yard with my nephews, and I fell, hurt my rib, went to the doctor. He said you need an X-ray. And this doctor is a member of a very large multi-state health system. Now I'm aware of how billing works. So when he told me I need you to drive down to the hospital and you go to the second floor and then they'll take your X-ray, I knew that I was going to get billed at hospital rates, provider-based billing. This is going to be a nightmare. And I happened to know that they had an X-ray machine there. So I said, well, can I just go down the hall? And we're not within 300 yards of the hospital, so you can't bill me those rates. And he said, no, the lady who runs the X-ray machine, and she's not here. And I said, well, I'm not dying. I can come back when she's here. And he said, we don't know when she'll be back. So I was a good little, trooper, and I went down to the hospital and got my X-ray like I was told to do. And I knew the whole time that this is a self-referral. This is generating cash. I mean, we know this game. If I'm a direct primary, I don't have that benefit. I mean, I may be able to do some of these diagnostic tests, but if I'm referring outside, I need people that are going to give me the best price and value for my patient. This is the beauty, I think, of DPC, is that it's a holistic look at caring for the patient, not just this particular moment in time, but I'm looking after your wellness. And there's a line in Marty McRee's book, The Price We Pay, that it plays in my head all the time, is that do no harm includes not doing financial harm. And if I'm caring for my patients and I want to refer them outside of my four walls, I want to give them options that aren't going to put them in bankruptcy. And that's what we think Allora can bring to DPC as well.
Awesome. Well, let me ask a little bit of a shift, really questions directly related to DPC and the future of DPC. And, like you mentioned with your product, I think there's some potentially some opportunity there for some crossover, maybe some referrals and so forth. But really looking at healthcare as an economic engine, in healthcare economics. I know, Devon, you said you're kind of interested in that space. And what do you think, or where do you see cash pay fitting into the future of healthcare in America?
Yeah, it's a great question. I think one that we ought to be thinking about more. And I think that people in America feel it, but maybe even haven't quite gotten the education that we have the opportunity to have to put it to words. But I think I alluded to it earlier whenever I was talking about the just increased cost value gap, right? So
Mhm.
with health insurance premiums, you're continuing to see a a continual uh, gap in what these companies are providing. And you have things like skyrocketing insurance denial rates. You have companies, I'm sure we all saw a little bit of this, like trying to use AI, and the first thing they're trying to do, instead of trying to help patient outcomes, they're trying to increase denials, right? Um, and that's just going to continue to be the case. Unfortunately, all the technology that Jonathan and I have the fortune to be able to create and sell to these to healthcare, those folks are way ahead of us. They're going to
Mhm.
continue to be fighting and trying to hold on to the coffers they have. So I say all that to say that the overall economic picture is such that I think that like if you're looking from a consumer perspective, cost of living is rises. Cost and that includes like base costs that we always talk about the grocery bill and everything. Like it's not just things like real estate, right? It's things
Right.
like everyday things that I'm paying for feel that they're hitting a growth curve that is unsustainable. So I do believe that what we're going to continue to see is that psychological pressure that could create the tipping point over to this really isn't how it should be. People talk about how it shouldn't be this way, but now there's options. And I think that's where cash pay is really important because, we've talked about how, in the past there's been things like, direct contract networks. There's been opportunities to go and to get labs drawn at cash pay rates or go get an MRI or whatever. Those places existed. But really, what we're talking about is visibility at scale, right? So I think that that's the kind of one of the missing pieces. The other thing I do want to mention is that I do know, the large insurance companies, they know that this type of psychology from the consumer perspective is there. I learned about an app that one of them has currently that is an app that comes with a plan that they offer, and it's kind of a bolt on to their normal commercial plans. But what happens is you do something very similar to what we're describing with Allora, but you search, you kind of look around, kind of like your in network, out network search, but effectively gives you there's no deductible involved, there's no anything, but just whatever the price is to you, all copays, and it's all based off of some math that they do on outcomes, patient satisfaction, and their negotiated rates. And so the reason I bring that up is because I there are people who are like who are a part of this particular network. They love that app and they love the ability to see that. Um, they think it's trying to mimic cash pay purchasing. It's trying to mimic how we would, like Jonathan said, buy food or search
Mhm.
for a service from a small business for my home or whatever the case may be. So we know it's there. We know the pieces are in place. But I think from just a broader economic perspective, I just think that overall we're going to see the pressure at the consumer level, which translates to the small business level. Small business drives this country, and so that will be kind of like the main drivers for change towards higher usage and adoption of cash pay.
Jonathan, anything to add on that?
Well, I think there's been a lot of positive movement from DC with regard to price transparency. And this is something, again, that's a bipartisan, by and large, a bipartisan effort.
Mhm.
There was a time not long ago that Bernie Sanders and Dave Grohl and Mike Lee, Republican senator from Utah, did a joint concert together to talk about the values of price transparency. So this is a bipartisan value here, and that's a great start. Health systems need to post their prices. That's common sense. We not only what your cash prices are. We want to see what you've contracted with your payers, because you have a responsibility to the public to make them in any market. That's you have a responsibility to make that work. So that's a really positive sign. Unfortunately, I don't know what the penalty still is, but I know when the price transparency rules were initially introduced, the fine was $300 a day. And that sounds like a lot of money to mere mortals like us. That's not a lot of money to a big health system that wants to hide their prices. And so they just
Yeah.
didn't play ball. And so I do think those penalties are probably going to get steeper. So that's going to help this cash pay market. People, consumers now have a choice to say, oh, you know what? By going to this one health system, I'm paying 10 times the amount I would if I went to this independent radiology center. And people need to know that, because ultimately it falls back on consumers to make wise consumer decisions. Unfortunately, the system is so complicated and so opaque to people that they have no idea what they're doing whenever they are engaging in some of these practices that have gone on for years. So cash pay is going to pick up steam in part because of the new price transparency rules, I believe.
Now, do you think anything that Trump is discussing right now will have an impact on that progress? Anything as far as policy changes, shifts, do you see coming in this
Well,
administration?
well, I do know that he nominated Marty McCary. I probably said his name wrong, to be the head of the FDA. Which he's a surgeon from Johns Hopkins. He wrote The Price We Pay. He has been very influential in the price transparency world, and I think he's one of the most important voices when it comes to reforming healthcare. And I don't think he has been confirmed through the Senate process yet, or I don't know the politics of it, so I don't know how that works. But it can't happen fast enough. So I don't know if it's the president himself or if it's just some of the people that will be in the administration. But I think there's room for optimism if you are on the free market cash pay side in healthcare. We shall see. Time will tell.
Yeah.
Lobbyists are powerful, but I am optimistic that some of the new voices that are in the administration will have some positive impact.
Well, they'll probably send like a 19-year-old guy that works for Elon Musk to go take a look. That seems to be the MO right now. So
Yeah,
who
that's
knows?
right. Yeah, that's
Who knows if Doge is going to go after healthcare or not? But interesting. Well, guys, I appreciate it. I do want to have a few moments before we wrap up this podcast to it's a new segment I'm rolling out today called Keeping It Reals. The concept is that I'm going to ask you some short questions. Give me a 15-30 second answer, and if it's a good answer, I will turn it into a viral reel slash TikTok slash X post. It will be all over the internet. And
This is terrifying.
if it's bad, it'll only be on this podcast.
well, there you
So,
go.
so either way, it's going to be heard. So, first off, Jonathan, I'm going to ask you this question. Um, what is the most surprising thing you've learned about healthcare?
The most surprising thing I've learned about healthcare is that doctors have no control anymore. Doctors do not run healthcare. It's run by 4-year degreed administrators. You want me to elaborate?
No, that's good. That's like
There you
10,
go.
15 seconds. Perfect. Devin, I'm going to ask you the same question. What's the most surprising thing you've learned about healthcare?
I think the most surprising thing I've learned is that, you have this. I've always had this perception of healthcare and doctors. You just realize that they're just people. There's bad doctors. There's people trying to just only make money off their patients, and then there's good ones. But overall, I've also been pleasantly surprised that there's a lot of good people in healthcare.
Awesome. Devin, I'm going to come right back to you with another question. This question is, if you had a magic wand, excuse me, let me ask that again. If you had a magic wand and you could fix one healthcare problem instantly, what would it be?
I know that there's a myriad of one we could choose from, but Jonathan, the one I would choose is I would wave the wand such that the EHR companies were forced to open up interoperability so that technology companies like us can integrate with them very quickly and easily and at low cost.
Jonathan, same question. If you had a magic wand and you could fix one healthcare problem, what would it be?
Site neutral payments. Whenever I get a procedure, it doesn't matter if I did it at a hospital or an independent clinic, the reimbursement should be the same.
Awesome. Thanks, guys. One more question and then we'll wrap up this segment. What is one tip you would give to any startup that's trying to make it in this world? Jonathan?
Spend time sitting behind the operators of healthcare and watch what they do. You will learn in no other way. You can read all the books in the world. You've got to sit and watch people doing the work.
Devon, same question.
Yeah, my biggest piece of advice is try to sell. So I think in the technology world, we get so caught up in creating the products and the thing that we're selling that just connecting with people and building relationships and understanding their problems goes a long, long way. It short circuits a lot of problems.
Well, there you go. That's a wrap for today's episode of the Best DPC Podcast, the world's number one spot for all things direct primary care. I do want to thank our tech geniuses, Jonathan Minson and Devon Mobley, for dropping some serious knowledge on us and giving us the inside scoop on Allora Health. We believe it will be a game changer for cash pay healthcare. Check out their website. So let me ask real quick, guys, how can people get in touch with you?
You can find us at calvient.com. That contact goes to all of us. Devon at calvient.com. I'm also on LinkedIn pretty frequently, so please connect.
Jonathan at Calvient.com. And I should also say Allora.health. That's ALLORA.health. You'll see a lot more information coming in the coming days on that website.
Awesome. We'll make sure to have that website in the show notes so that everyone who is listening or watching this can find it themselves. Don't forget, if you had as much fun as I did, go over to bestdpc.com for more DPC goodness and resources. We want to keep this conversation going, so follow us on social media for the latest updates. And don't forget to subscribe to our YouTube channel. And whatever you listen to podcasts, we're there. So just download the episode wherever you listen to your podcast, and we will be back and give you more great DPC knowledge. Until next time, this is Wayne Lowry signing off. Remember, your health matters. Demand the best. Direct primary care. Bye-bye.
Best DPC podcast. We're spitting truth on the mic. American healthcare stinks. A maze of red tape and greed that's out of sight. It's time for new choices. A revolution in care, where every heartbeat matters. Cutting through the noise with direct primary care that shatters the status quo and lights a fire in our souls.